Nigerian health authorities have observed a notable increase in diphtheria cases across multiple states. About 800 confirmed cases have been reported since the outbreak began in December last year. Among the affected states, Kano has been hit the hardest with 782 confirmed cases. Other states reporting cases include Cross River, Kaduna, Katsina, Lagos, Osun, and the latest being the Federal Capital Territory, where a 4-year-old died of the disease. Diphtheria is a highly contagious infection that can be fatal, especially among children. The Nigeria Center for Disease Control has confirmed 80 deaths in the ongoing outbreak. Of the total number of infections, unvaccinated individuals, many of them between the ages of 2 and 14 years, make up 654 cases. You may recall that the NCDC is already battling with COVID-19, anthrax outbreak, flu outbreak, and now diphtheria. Let's have a chat about this now. I am Kemini Amano, and you're welcome to The Square. Joining our gathering today are Dr. Tuyi Mebawondu, who is a public health physician based here in Lagos, Nigeria. We also have joining us from the Netherlands, Dr. Philip Ingemanzi. He's chairman of the International Institutes of Advanced Research and Training, Chidekong Medical Center in Holland. Gentlemen, you're welcome to The Square.
Thank you.
Indeed.
Thank you for having me.
Absolutely. I do want to start with you, Dr. Mebawondu. What are the primary challenges faced by the NCDC in responding to diphtheria outbreak while concurrently managing these other outbreaks, anthrax, the flu, and then COVID-19 still, every now and then rears its head?
It's legion. If you want to look at the problem shaped by Nigeria Center for Disease Control, the problem is legion. It's a lot of problems, human resources, capacity, finance, and even the government commitment, quite a lot. If you observe this outbreak, why we have to have this outbreak is simply because, you remember the COVID-19 prevented a huge gap, caused a huge gap in vaccination all around the country, because normally diphtheria is to be prevented by vaccination of children. Of course, as we are now, we're having as much as, just 36% or 30% coverage in childhood immunization. So this is going to create its own gap. But if you look at CDC, you're looking at funding. It's a problem. The fund is just there. It's not just available, of course. You know that Nigeria is facing its own big challenge. Funding, human resources is there. Then three, what I would call misinformations. Are people believing in the wrong thing? Those things are just there, causing a lot of problems, preventing response, preventing reportage. And of course, if you look at the number of our healthcare workers, it should be directly proportional to how you respond to your diseases. Doctors are not there, epidemiologists are not there, the local government health workforce are not there, These are some of the problems that are combined together to affect the functionality of the Center for Disease Control.
Indeed. One of the things that have been identified in this case is the number of unvaccinated people who are getting infected, particularly, as I mentioned earlier, in Kano. But at the same time, we also know that Nigeria is one of those places in West Africa that has not completely rid itself of diphtheria. But to think that we are in 2023, that must be concerning for you, Prof. Why do you think that Nigeria is behind when it comes to diphtheria vaccinations?
Yes, I think this is related to the overall health architecture of Nigeria. Just by way of introduction, this infection is caused by Corynebacterium diphtheria, and we have a vaccination schedule for that. So there is the triple vaccine. There is the DTaP, which is diphtheria, tetanus, and pertussis, which is called whooping cough, and then there is the Tdap, which is tetanus, diphtheria, and pertussis. And then you have diphtheria, tetanus, and tetanus diphtheria. This schedule is well laid out, but the overall health architecture in Nigeria is deficient. And what happened is that we designed a colonial health system which did not, until recently, just we started integrating the preventive arm. There are always three arms of medicine: the preventive arm, the therapeutic arm for treating patients, and then the arm for research. These three tripod is what the health system stands on. But unfortunately, we just inherited the colonial arm, which had, even at the beginning, it had some level of preventive arm. The other two arms were deficient. And unfortunately, to this day, we still are preserving a health system which is grossly deficient. But we have been talking about it. I was, for a very long time, part of the private sector leadership of the private practitioners of Nigeria. And we have been talking that this health system has to be redesigned. If the NCDC is operating mainly in the public health sector, and that is not correct. We have to integrate the private doctors in every locality, in the villages, in the town, all across the country. Because if we do that, this vaccine hesitancy will be overcome because they are going to the doctor. They already know. People don't go to hospitals, they go to doctors. And that's what we need to do in Nigeria, to redesign the entire health architecture, that it is now integrating the private sector arm, which is actually the majority. If you go in Imo State, where our hospital is resident, we have over 85% is in the private arm. So what will be the outcome when you're trying to use 15%, which is in the public health sector? The effect and impact will be very, very low. And that's exactly what we expect all across the country. So it is a matter of redesigning the health system. The NCDC should be designed to work within the arm, both in the public sector and in the private sector, and using the private practitioners to administer vaccines according to the designated calendar. So the failure of coverage is just a matter of self-inflicted poor health system design. And we thought that this call, there should be a much more synergistic approach. You can actually offer the doctors a lot of incentives. You give them tax holidays, give them free
so you would look at
access to materials, and that will encourage private practitioners to be integrated in the preventive arm of medicine in Nigeria.
Indeed. I want to come back to you a little later. We'll talk about, what the NCDC is doing now, and also build a bit more on redesigning the public health system or the health system generally, as you said before. But let me move on to Dr. Mebawondu now. Doc, let's talk about vaccination, but also look at Kano, which appears to be epicenter for the outbreak right now. Over 700 cases in Kano alone. Is there something, or is there a condition in Kano that makes it very rife for the outbreak to, wave across the states? And on the issue of vaccines, are these vaccines even available at all?
Now, let me just also buttress what the prof said, essentially. Nigeria is a very confining situation as far as health is concerned. Of course, some of us have actually been on the forefront of engaging the totality of the health infrastructure, including the human resources, both in public and private, to drive the health system. But in fact, we are creating a lot of silos whereby the private people don't know what the government is doing, what the local government don't know what the state government is doing. Everybody is in silos. And you don't get good health system when you work in silos. And Kano is peculiar. There are cultural, there are religious issues affecting vaccination. You know that a lot of disinformation and misinformation came as a result of COVID-19. And of course, these things are still hanging on. Of course, we will tell you that, look, I didn't take vaccine. COVID vaccine and I'm alive, nothing happened to me, that those of you that took the vaccine, so anything will happen to you. That is still and we're not interrogating those kind of discussions. We're not trying to look at how exactly do we reduce those kind of negative narrations concerning vaccination. And then Kano is because one of the key factors, that's one of the key factors that tend to help the spread of or the outbreak of diphtheria. Overcrowding, no immunization, no immunity. There's immunization, there's no immunity. If you look at the trend of malnutrition in the country, of course, the northeast, stands out clearly. And of course, the northern part of Nigeria, northeast stands out clearly, and Kano is a part of the northern part of Nigeria. Secondly, you look at it, there's a lot of overcrowding, and then the weather is dry, quite dry, which actually, helps to the spread of, because diphtheria is spread by droplet infection, it's spread through surfaces, so it allows all this to happen. Then secondly, the immunization rate is so low. Nigeria's average immunization rate is about 35% between 2016, 35% since 2016. That's extremely low. Now, you will see that even the lower rate will be seen in Zamfara State, will be seen in Kano State. So the immunization is not happening because the trivalent immunization, the DPT that you used to give in childhood, they're not giving those things again because one, COVID added to the budget and a lot of things happen. So they're not stimulating those. It's a clear pointer to the fact that the county government is not doing enough in health. This was where a lot of, even last time that you saw it there, even outbreak of meningitis, outbreak of so many diseases tend to come from Kano. So there's something about the public health of Kano that will not get it right.
But okay, so could there also be the case of patient attitude or people's attitude towards the vaccines, in that they are rejecting the vaccines? Dr. Mebawondu, is that a possibility?
I mentioned the cultural and religious aspect.
Right.
In that sense. Yes, I did mention that. And there's a superstition and, being involved. People are superstitious. They say that they cannot take this because of that and that. So these are factors that are feeding into it. And of course, if you look at the main people that determine authority in Kano, remember, we had outbreak of meningitis because in reality, there are rumors that some people are coming from abroad to reduce the fertility. I can remember when the Islam broke then. And because of that, a lot of people abandoned the vaccination. Okay? Now, the center, those people that actually, the leadership in those communities are actually the religious leader. You don't have authority as a family or as the head of the family, but as a religious, you have to listen to your religious leader. So the kind of campaign you need to do in Kano will be different from what you do in Ghana or in Nigeria, for instance. So, you have to make it so specific, target the religious leader, encourage them, incentivize. For me, you will incentivize.
We'll talk a bit more about, patient care in a bit, but let's talk about the Diphtheria Technical Working Group. And Prof, I'm coming to you. The NCDC set up this working group to coordinate activities including tracking, surveillance, and immunization. How significant is the work of this group going to be as far as nipping this outbreak in the bud is concerned?
Yes, I think it's commendable that the NCDC is mandating a committee to do that surveillance. But the problem is, where are they peripheral? That means from where they will collect this data. And what it means is that you have to use existing hospitals.
Prof, it seems we have lost the audio from you. For some reason, we can see you, but we can't hear you. If you can hear us, we would want you to adjust your audio device so we can hear you also from here. But in the meantime, I'll move on to Dr. Mebawondu. Doc, I was saying that we'll talk a bit more about patient care. We also know that, the the outbreak is concentrated amongst children between the ages of 2 and 14 years. Is there a reason why that demographic contributes the most to, is contributing the most to the outbreak?
Obviously, first and foremost, the immune system of those children are still developing. And then the respiratory system, the main target of the diphtheria, is also still developing. The respiratory system of a young child is not actually matured more than 7 years or so. So that is why you see recurrent respiratory infections happening in those children. And of course, respiratory infection is one of the commonest killers of those other 5 in a way. So everything that has to do with droplet infection spread in the air can easily affect these children. So immunization is one. Secondly, the respiratory system and the immunity. Okay, these are the factors that came together. And then, in fact, if you are talking about overcrowding, they are likely to be more of the victims of that overcrowding in the sense that they tend to aggregate them, put them in a small room together, where even cough.
Right. Well, for some reason, the connection has gone off again, but I do have Prof. So I'll take Prof's thoughts on the technical working group and how they could impact or control the outbreak. Prof, you were telling us earlier about your thoughts on the technical working group and what their strategies, how their strategies could help control the outbreak.
Yes, and I was just trying to recap what I said earlier. The technical working group is very commendable. They have started some work on this, but they should use both the people in the public health system and the people in the private sector to collect their data. We are already doing that. Just to give you an example, the care in tuberculosis, for example, in Nigeria, has improved dramatically because the technical working group on tuberculosis is using all the private sectors, the hospitals, to do that. So I think this would be another example whereby they could improve their outreach through the private sector. And that will remove this skepticism and doubt about the effectiveness of the vaccine because they're already hearing it from their doctor, right from title. So I think what we need is a grand redesign of the approach of healthcare prevention of diseases in Nigeria. Once this is done, I think NCDC will have a very major impact. And the doctor already had mentioned about budgetary system. The money that is given for prevention is too low or insignificant. We have actually contracted that out to international agencies to provide us some money, to do our own healthcare problem. No, I think we should put health on a very high list, and prevention should be number one. So I think we should dedicate more funds. That 15% fund must be directed to health, and we should be able to provide 5% to prevention, 5% to therapeutics, and 5% to research. That should be a more rational approach, both at the federal level, state level, and local government level.
I see. Speaking of vaccines, we have also been informed that at least over 100 of the infections that we have seen are from people who are already vaccinated. Doc, explain to us, the public, outside of the medical field, why we should continue to vaccinate if we'll get there is the chance or possibility of getting diphtheria anyway.
Yes, the issue here is that it's not just one-time vaccination. Entitled at 2 months, 4 months, and 6 months, there was supposed to be the triple vaccine. Now, you have to repeat that at least 2 other times entitled. Then by the time you get to presteen, 11 and 12, you have to also do the vaccination, and the adults have to have vaccination every 10 years because the vaccine is thought that you need to booster the dose at given levels. If you do not do the booster and the titer of the antibodies go down, then you are not protected. So that's why we have to do this. It follows that schedule, and you know, people might say, okay, I've had the vaccine. Yes, you've had the vaccine, but you are way off the time when you are supposed to get the booster dose.
I see. Let's talk a bit more about the NCDC and the work you're doing. Like, you know, like I mentioned earlier, the NCDC at the moment is already saddled with COVID-19, with the anthrax outbreak. It also had flu outbreak in the system, and then now it is dealing with diphtheria. Do we dare say that the NCDC, as you know it, may be stretched at this point to deal with all these public health concerns effectively, that is?
Okay. Now, this is also the design of the NCDC is very deficient. I must say this, you know, this might come as a surprise. Before, in the First Republic, we had the Surgeon General. The Surgeon General was the third person in the Nigerian hierarchy. So that will tell you how important preventive care was. So you should have the head of the NCDC, call him Surgeon General in this case, should be at the federal level. And you should have the state Surgeon General. And you should have the local government Surgeon General. And even at the ward level, you should have Surgeon General in a given ward. These are doctors who have been giving the prime task of disease prevention. And then, of course, if we funded it with the network, then this will most likely be very, very efficient. What is happening now, we just have a thinned down system where we saddle a few people in the network, relatively few for 200 million people, with the task of disease prevention. And this will never work.
Right.
So
which is why you have said they should be working with people at the grassroots level, so to speak, including private sector, to roll out vaccines and preventive measures. Gentlemen, what I want us to do now is take a break. When we come back, we'd like to talk about the disease itself, preventive measures that people could observe at the individual level, even as we have spoken about, you know, how we could prevent this at the national level. You're watching Village Square Africa. I'll be right back. Welcome back to the Square. Today we are discussing Nigeria's diphtheria outbreak, and still with us here on the Square, Dr. Tuyi Mebawondu, who is a public health physician. He's here in Lagos, Nigeria. We also have Professor Philip Injemanzi, who is chairman for the International Institute of Advanced Research and Training. He's based in the Netherlands. Gentlemen, thank you for your patience. Doc, we lost you there for a bit, but thank God that you're back on the connection with us. I do want to say to our viewers at this point of our conversation, I feel obliged to tell you that this is not a conversation that should substitute medical or professional advice. If you feel that you experience something that could be diphtheria, or you feel sick in any way, you should go to a medical facility and get some help. That said, Dr. Mebawondu, I'm coming to you now. We've talked a lot about what we are doing about the outbreak. Now let's talk about the disease itself. What really is diphtheria?
Yeah, a bacterial infection, primarily spread by, can form spores, can form toxins. So I spread through either droplet contact, you are sneezing, you are coughing, or can even spread to the surface. When there's some surfaces that are contaminated at touch, then germs. But germs has an incubation period of 5 to 10 days. So that when that can cause it to from either on the skin or the genus form of bacteria, or those which form which we call the long form, throat form of diphtheria. Two ways. Once it enters the throat, first thing is the constitutional symptoms. When somebody feels first, constitutional symptoms that but then subsequently the hoarseness of voice muffled, and doesn't have serious headache, and then before you know it, leads to a lot of damage at posterior part of the throat, and leads to complaint of what we call a PEM, and then respiratory damage, respiratory obstruction, the toxin is absorbed, gets heart, damage heart, and it actually cause paralysis. Fatality percent about half of the therapy tends to die, very severe form. But the cutaneous form is not that serious because the absorption rate of toxin is very low. So, reality, if you're going to pay for the player, you pay for the cutaneous form for that the one that affects the throat for challenging faster. So, that is it. But of course, it requires a doctor to pick it and respond.
Absolutely. And I was going to get into that. Maybe I'll draw in Prof at this point. Prof, when you listen to the symptoms that Dr. Mebawondu has outlined for us, sound a lot like the flu also. And so while it would be difficult to self-diagnose at home, and we advise that you go to a medical facility, I just want to find out from you, from the medical point of view, does that pose any challenge in diagnosing diphtheria in the 21st century?
Actually, the good thing is that you can do a very good clinical diagnosis. The danger from your normal cough of respiratory illness is that there is a sheet it forms, the bacteria forms, that can close your airway and you can't breathe. And that's the thing that actually kills most of the patients. Then in the spread of why it's so dangerous, and that's why we will tell people the mask is back, okay? Is this sneezing and coughing that spreads it, especially in a closed space, like traveling in a bus, where people are in very close proximity. So anybody there with diphtheria can actually spread it to the entire people in the bus. So we are going to be going back to the using of the mask, especially in public transport. So the most important thing here is that to be able to spot yourself that you are actually not feeling fine.
Right. So, Prof, are you saying that for places where infections are known at the point, particularly like the epicenter in Kano, are you saying that people should resort to wearing masks in public spaces where there are crowds?
Yeah, this will be a very important precautionary measure because at this time we in a very densely populated place like Kano, there is the possibility that we could have a major outbreak affecting many, if not millions of people. So a mask would be a very good, be of very good help for many, especially when you are crowding in a bus, a small bus or Danfo or something like that. There is no way, if somebody is sneezing and coughing in the bus, there's no way you can escape it. The aerosol will just spread among those people in the bus. So if you are wearing a mask, you will be well protected.
I see. Dr. Mebawondu, I come back to you still on patient matters. One of the things that the NCDC has spoken about is the fact that health workers should be on the alert. My guess is to prevent misdiagnosis. As I've said earlier, it would seem the symptoms of diphtheria and the flu are very much alike. And we might need more clinical diagnosis. But my question is, how well-resourced, how prepared are these health facilities based on your experience to ensure that misdiagnoses do not occur?
Well, tell you what, we are aware that there's an outbreak. We're aware that it's going on some parts of Nigeria, and we've seen the number of deaths possible. So that sort of raised some concern among the practitioners that now, when you see the constricting or the constricting nature of breathing, when people cannot breathe and always hoarseness of voice, and then you look, because normally part of the tradition is when somebody is complaining of sore throat, when you throat and you see the membrane, and that's so the doctor following the basic of that or basic having said that, the key thing is to maintain high temperature among them. But going back, what's so important that cheapest we can deploy right now is information. Talk, signaling, talk to people, government must talk, religious body must talk, no government must talk, we must enlighten people. But secondly, it's so important that since prayer is going around, we need to really wrap up the immunization to be vaccinated, vaccines systematically, and that should involve everybody. Health does not belong to the federal government or state government alone. Health belongs to everybody. And we see a lot of, like Prof said, a lot of private doctors, working in the community, make use of them. Cannot know, cannot work all good. So then, thirdly, of course, we need to be able to do some guide and support to that having that those that are keeping that now. Interestingly, good enough, you have antibiotics that can take care of viral. But a more serious case of chronic bacteria may actually require information and actually critical care. So, how many of doctors that are providing this care? 24 to 30,000 doctors in Nigeria, the majority of them consent. How you would respond?
Very well. So, Doc, would you say that there is enough education going on around diphtheria?
There is not enough education going on. The education going on is political stories. Who is doing that? Who is going to come? People neglect that when start killing them and start shouting for panic attack. But what I'm saying in essence is that you are devoting your airtime to discussing this issue. I expect also that even at the level of state-based organizations, at the level of religions, at the level of NGO, at the level of the local government, mosques and churches, we should talk about this and let's do appreciate the fact that this is Quran and this is prevention. Of course, even when it comes to this, the basic care of cleanliness, wash your hand, cover your face, cover your mouth, sneezing into another country. You still do those things, but it seems to be practical in our thinking.
Right.
Believe that, and of course, God because we will take us from it.
Indeed. Indeed. I come back to you, Prof. Now, one of, being a bacterial infection, we know that antibiotics will be really important, but we also know that West Africa has been one of the places experiencing antibiotic resistance. How much of a challenge do you think it could pose to the ability of public health workers to nip or control the outbreak?
Yes, actually, you rightly mentioned that there is some level of antibiotic resistance, but God so thanks that what we have now can still be very effective for treatment. However, the problem about antibiotics is that's the abuse of the drug. So people who do not need to take the drug will be taking the drug even when they have symptoms that may not be related to diphtheria. And this is how they get resistance because or they take the drug in suboptimal doses, and then that allows the bacteria to acquire plasmid factors and be able to resist the treatment. So I think the shortest cut to that will be directing the patients to doctors. and also being able to supply these drugs, the genuine drugs, because we have many substandard drugs in the country, unfortunately so. To supply both the private and public sectors with the genuine drugs, and then make sure that they dispense it to the patient according to the contract. So I think it's a lesser of a problem. The antibiotics resistance is a lesser of a problem in health institutions. It's when they are being bought across the counter in pharmacies and dispensaries. Yeah, that's when you really run into that problem.
Dr. Bebewandu, you know, when I was asking the question, I saw you nod. Tell us what you were thinking about how antibiotic resistance could affect the intention to control the outbreak of diphtheria.
It's a big issue in the world now. In our own particular situation, you see people on the street talking about it, people buying the street, selling all sorts of drugs, and invariably, all those drugs are substandard. Another challenging factor is that even before people come to you when they're having cough, when they have hoarseness of voices, fever, headache, they've used the medication. Actually, provides a lot of cure or treatment or effectiveness of those antibiotics as well. So, two main things: drugs being hawked, drugs being sold even by pharmaceutical. Secondly, the fact that even patients have already taken one or two antibiotics at poor and they come to an advanced stage. When they come to an advanced stage, what can you do? Then, what you have prevented and now trying to with complication. So, antibiotic resistance is the next big issue.
Indeed.
Which
Absolutely. Prof, take us home on this discussion. For someone listening, realizes that they are not vaccinated as far as the childhood killer diseases are concerned, diphtheria is in the air. Is it too late for people to get vaccinated?
Yeah, it's actually not too late. For adults, every 10 years they should be boosted with a vaccination.
You don't mean it. Every 10 years?
Every 10 years.
Well, now I feel unprotected.
Because actually the vaccine is very good. So it can actually give you some level of protection. Then, of course, for the childhood vaccination is 2 months, 4 months, and 6 months. So that's the triple vaccination. And then for preteens at 11 and 12 years and 4 and 6 years. So you really, if you have not been vaccinated, you can still key in into the vaccination calendar. And then once you are vaccinated, depending on your age, then they will know when the next schedule is for you. So you can still use the vaccination, even if you have not done it over the past 10 years, you can start now.
I see. Thank you, gentlemen, for your time here. Dr. Bebewandu, are we in the same boat of not having boosted our diphtheria vaccines? We are, aren't we?
But we have to give chance to those children.
I agree with you.
Taking their shots, we should be able to be more careful. They are more at risk than us. So take their vaccine.
You make a solid argument for us. Thank you so much, gentlemen, for your time here on The Square. I hope to see you again on other matters.
Thank you for having me.
Thank you.
Thank you, too, for watching. Remember, I told you that our conversation today is not substitute for medical or professional advice. If you feel ill or unwell, go to a medical facility and get professional help. My name is Kemini Amano. This has been The Square. I hope to see you again, same time tomorrow here on New Central TV. Bye-bye.